Good morning, everyone. Thank you for joining us. My name's Don Novo, and I'm a managing principal with Health Management Associates. I'm thrilled to be here this morning and to have Meaghan Kramer with us. Meaghan is a senior policy director for Governor Catherine Hobbs, and she's going to speak with us today about a lot that's happening. I think if we were here last week, it'd be a very different conversation. So we have a lot of interesting information that Meaghan's going to share with us. She's going to talk about the state of healthcare in Arizona and some of the changes and things that are in flux right now. And then we look to talk a little bit about some of the initiatives that the state has put into place and some of the work that they've done with fraud, waste, and abuse. And if we have some time, we're also going to talk about how Arizona is processing some of the potential federal Medicaid changes that have been floated at the federal level, and that states and policy directors and Medicaid agencies are starting to really kind of process and make some make some planning on how they'll address if those changes are implemented in whatever form they come to in the final format. So with that, I'm happy to introduce Meaghan. I appreciate her joining us today and having a great discussion about the state of healthcare and some of the changes that are happening.
Well, thanks, Don. Among the other things in flux is my voice, unfortunately, everyone. It was better yesterday, and I've been doing a lot of screaming into the void, as many of you have been, so I promise to make up for it with content today. I think what I wanted to do was kind of start by talking about the elephant in the room, which is I am not Carmen Heredia. I do not work at Access. And I just wanted to spend a little time addressing what has transpired and how we came to be without a director of both Access and the Department of Health Services. And yesterday, you may have seen that Barbara Richardson was voted down by the Senate as a whole, so the Department of Insurance and Financial Institutions is also going to lose a talented director. I just wanted to sort of start by talking about what this isn't, which is I am a Democrat, I work for a Democrat, I spend a lot of time disagreeing with some of the legislation that comes up from the legislature. There are legitimate policy differences with respect to healthcare that we see all the time, but I just wanted to name that what has transpired is that three very talented women who saw wide approval from health plans, hospitals, civil rights organizations, providers, universities, you name it. You guys don't agree on everything, but widely there was agreement that these were three people who were qualified to do the job. And by the way, they've been doing it and doing it pretty well for a number of years now. And I just wanted to be clear, we're still in the sort of days after the conclave, so to speak, has not met to determine what we're going to do next. All of these agencies are in sound hands with the leadership of some of the deputies who have stepped up to take over some of these key responsibilities. But it's critical that we recognize, and I do not think this has been reported accurately in the chaos of everything else that's happening in the healthcare space, that this is something different, that this was fully pretextual, that any allegations of corruption are unfounded. Do your public records requests, there's nothing there. These are people who have inherited a very challenging time in the healthcare space in Arizona and have done tremendous work. And then Medicaid cuts, became on the horizon. And so this is a perilous time for healthcare and for public health. And I just wanted to sort of name that and make sure that we all sort of level set at the beginning. That's what transpired. We did not ask for resignations because people were unqualified to do these jobs. And I'm not sure, I think it might make sense to spend a little bit of time on fraud, waste, and abuse, I guess.
Yeah, do we want to talk a little bit about that? Because I know that, one of the things in our pre-conversation that you really talked about some of the great work that's been done at Access and some of the other agencies in that regard.
Yeah, it's fortuitous that fraud, waste, and abuse is sort of a popular topic right now because Arizona has unique and perhaps the best experience of any Medicaid system in the country in combating fraud, waste, and abuse, sort of flowing out of our behavioral health fraud that is sometimes referred to as the sober living crisis. Many of you know there was a series of schemes that kind of started in Nevada and came down to Arizona and mainly targeted our fee-for-service program, but there was, fraudsters are creative and they inserted themselves into a number of different lines of service at Access and in some private health plans. And Access for years now has been doing a tremendous job sort of becoming the experts in fraud, waste, and abuse. And no kidding, CMS turns to Access for how to do this stuff. And it's really been a point of pride for this administration that under the leadership of Director Heredia, we sort of brought to an end the significant fraud that was flowing from that behavioral health scheme. Now, there's still fraudsters out there. You can never completely eliminate fraud, waste, and abuse, but the programs that they were targeting in Access, we have just seen the numbers level out to where they were before any of this started. And, I just wanted to make clear that before any of this, before Access really started to attack the fraud in all the ways you have to attack it, you don't just chase it, you have to turn off the faucet, and you have to do a better job vetting your providers. And it's tremendously complex, and all of the different areas at Access that have worked on this together have really been a model for the nation. And at some of the conferences on program integrity, it's our people from our Attorney General's office and from our agency, from our Office of the Inspector General, who are teaching others how to combat fraud, waste, and abuse. And the way that you do it is not with a, what's that thing called? Chainsaw. It's not with a chainsaw. You need to do it with a scalpel. That's how you attack fraud, waste, and abuse. You have to be precise. You have to study data. It takes time. You need to do it in a way that does not unduly impact your providers and your health plans, which is something that Access has had to make adjustments along the way. We're still learning how to do this in the best possible way, listening to stakeholders, but there is a way to make big changes, and sometimes it requires an administrative spend. Access had, as a point of pride, had some of the lowest administrative costs in the country in the years leading up to what has been reported as a couple $1 billion fraud. And if you can draw a straight line from not spending a lot of administrative dollars to $2 billion in fraud, what have you got? And so I think that sort of, and we can learn a lot from our managed care plans in how to prevent fraud, waste, and abuse, and how to attack fraud, waste, and abuse, prevent it before it happens. And I think that Access has done that and continues to do that and collaborate with our peers at the managed care plans. And I think that's the main thing I wanted to say there is we're continuing to do that good work. There is always going to be fraud, waste, and abuse in Medicaid. As long as you're doling out huge sums of money, people are going to try to take it. But Access, I think, is doing it well in collaboration with a lot of people in this room. And I think there's a lot to be learned nationally and at other Medicaid systems about how you do this well, and really proud of the work that Access has done over the last several years.
Yeah, and I know, Meaghan, during my time at CMS, Access was one of the premier programs that, federal officials really look to as kind of a role model for, operating effectively and efficiently and cost effectively. So even at the time with the MMP, the Medicare, Medicaid projects, Access was light years ahead of some of those models with its managed care programs. So appreciate you sharing that information. Maybe we could spend a few minutes talking about some of the proposed changes at the federal level and how Access and the administration is kind of looking at some of those options, because we know that a lot of what we've heard at this point is really kind of in play. So there have been a number of kind of proposals that have been floated around regarding changes in FMAP and expansion populations and, kind of the impact that will have on the system overall. Why none of us have a crystal ball and are really able to kind of pinpoint what the future may look like. We know that there will be changes, and I think, at this point in time, what Access and many states are doing really is looking at what those, kind of high-level proposals would do if they needed to be implemented.
Yeah, and I think we're going to do a little talking about this afternoon or later today. Mercifully, I'm going to have some other people with me. Beth Kohler from the health plans and Brittany Kaufman with the hospitals are going to help sort of level set a lot of this stuff. But I think it's helpful to talk about what Access is before we really sort of delve into what the potential cuts will be. So there's about 1.7 million Arizonans on Medicaid, and half of those are elderly people and children. And that's really important because there's a lot of talk right now about, there's a bunch of this term able-bodied men just sort of sitting around playing video games, getting free health care. I think the data shows that's not what's actually happening. 40% of them are kids, 10% of them are over 65. And it costs a lot of money. As programs go in Arizona, we're spending $21 billion a year in state and federal monies on Access. And 3/4 of that is coming from the federal government, okay? So this is not something that we can afford as a state to fund on our own. We have never funded this solely with state monies. So it's a significant portion of our population that's on Medicaid. We have 23% of Arizona's population, which is about 7.5 million on Medicaid. 48 roughly percent of us are on employer-sponsored plans. And of the folks on Medicaid, I think it's important to talk, when we hear this language, able-bodied, that's not in the Medicaid statutes. And I came to the governor's office from the disability advocacy space, and so I think, the phrase able-bodied is very offensive. It doesn't have any meaning with respect to disability and sickness and health. And so I think it's just important to talk about some of the numbers. So here's what we know from Access's records. 180,000 of them have diabetes. 430,000 of them have heart disease, heart failure, some other chronic heart condition. 660,000 are struggling with COPD, asthma, lung disease, some sort of respiratory disability. 68,000 have opioid use disorder, and this is in the middle of a peak in our fentanyl crisis in Arizona. 54,000 of them have schizophrenia or some type of psychosis. 30,000 of them have attempted suicide or have suicidal ideation. 48,000 have autism. These are diagnosed cases of autism. 65,000 have cancer. 5,000 are undergoing organ transplants or post-transplant care. 65,000 are pregnant or have just given birth, and 77,000 have some kind of disabling congenital condition. So these are not well people. we're dealing with sick people, and it's a fallacy that the people who are Medicaid expansion folks, who are sort of on the chopping block in these federal discussions, are healthier than everybody else. Actually, the data shows that they're sicker. So all in all, that's about a third with some kind of endocrine disability, a third with a respiratory disability, and a third with the behavioral or neurodevelopmental disability, and there's some overlap there. And then within that population, we break them up into different groups. There's the traditional Medicaid population. That's who we think of when we think of sort of traditional Medicaid. Lots of women and children. That's 1.2 million Arizonans. And then we have the expansion population from Prop 204. These are the voter-protected group. And we get 90% of the FMAP for that group. That's 90% federal match. And that's 450,000 Arizonans who are voter protected, receive Medicaid, and these include what we call the childless adult population with incomes up to 100% of the federal poverty level. And that passed in the year 2000, and I just sort of wanted to go back and remind everybody, what was the political climate like at the time that we voter protected Medicaid in Arizona? And here's what else happened on that same election. One, we voted with an overwhelming majority to have English-only education in Arizona. And two, Al Gore got just destroyed in that election by George W. Bush, and a very working class county, Greenlee County, for the first time in Arizona history, voted for the Republican nominee. So it was not like a blue wave that carried in Medicaid expansion. And this is just to demonstrate this is not some blue-red issue. Medicaid is about essential care, and it crosses partisanship. And so I just think it's important to emphasize that at every chance we get, because I think it's being framed by some as like a political issue right now, and it just isn't. It hasn't been traditionally in Arizona. And then of the remaining sort of large groups, we have the expansion population under the Affordable Care Act, and that's another 90% FMAP match. And that's about 70,000 Arizonans. And this is the one where we have a trigger clause. So if the federal match drops below a certain amount, Arizona is just not going to fund it. And then we have All-Tex population, which is our long-term care, and that covers 75,000 Arizonans. So that's kind of what we're looking at. It's a complex sort of bunch of buckets, and every Medicaid system is different. Unlike Medicare, the states are in charge of their Medicaid systems, and that saying, if you've seen one Medicaid system, you've seen one Medicaid system, because they're all extremely, extremely different. But that's what we do here in Arizona, and that's sort of the bare bones background going into these discussions.
And it's interesting too, because you speak about the vulnerability of these populations. I mean, and when you talk about even just the Medicaid expansion population, they're determined that their income qualification is 138%. And I think when we talk about that and say, well, most people don't know what 138% is of federal poverty level. It's about $1,200 a month. When you think about how low that amount of money is for someone that's paying, housing and support and then dealing with payment of medical issues, I mean, I think it really paints a very different picture of kind of the vulnerability. Not only do you have individuals that are dealing with, chronic conditions in most instances, but very low income as well, and, a kind of an environment where housing and all of the economics are just really stifling for people that earn significantly more money, never mind those of low income.
Yeah, that's absolutely right. And I think, the other piece of this that's so critical is the economy piece. So there's a lot of, it's very complex, and like I said, I invite you to come to our conversation later today about sort of the different moving pieces and options with respect to federal reform. But there really isn't anything that's going to get to this $880 million cut that is being contemplated in this, quote, big, beautiful bill that's going to make a significant change without basically devastating Arizona's Medicaid system. And, there's a lot of different ideas floating around, and, things are moving 100 miles an hour and also epically slowly in the Beltway. And so, like, the latest reports are that the FMAP, yesterday the moderates had a very successful conversation, and FMAP reductions are off the table, and, per capita caps are off the table, and also everything is in flux, and they've got to get to a majority, and it's simple math. So I just wanted to talk, we talked about the fact that with respect to the ACA, there's a trigger clause, and we would not make up the funds. When the governor gets asked questions about this, like, are we contemplating backfilling? Are we going to backfill with the state funds? Are we going to tap into the rainy day fund to make up for this loss in federal funds? And I just want to be absolutely clear, we do not have money to do that. We just don't. I mean, we barely have money to pay our existing bills. And so I wanted to spend just a little bit of time talking about our budget. So our state budget is about $16.5 billion this year. It's going to be $17 billion probably next year. That's what the executive budget is. And $7.7 billion goes to education. The ESAs cost more than $1 billion. DES and corrections get about $1.5 billion each. $500 million for child safety, $1 billion to the universities, $400 million to run the state. That's just administration, which is tremendously efficient nationally. And then $2.5 billion for a lot of other things, which is bare bones: public safety, roads, housing, community college, professional regulation, and the 125 other state agencies and departments that we are obligated statutorily to run. And so that leaves like $125 million to health services and $2.6 billion in general fund dollars to access, with another like 4.5 in non-appropriated funds. And that's it. And that's what we're doing now. And so, when we hear the different sort of concepts for what it would look like if some of these reforms were put into place, we do not have several $1 billion to bail out the federal government. We just don't. We would have to increase taxes significantly, which is not in the cards, and we cannot rob from any of these other programs. And so, with respect to both Medicaid expansion populations, there isn't any money. And the rainy day fund is not intended, first of all, it would not sustain this type of loss, but it's not intended for this. The rainy day fund is intended for a rainy day, and this would be a federal permanent drought. And so I think it's critical to kind of keep that in mind. Basically saying, well, we're putting it on the states. The states can decide whether they're going to do this or not. We can't. Some may be able to, but we cannot here. And so that's just sort of critical to keep in mind when we're talking about what this is going to do to not just health in the state, not just to the places you guys work for, but to the economy, the Arizona economy. Healthcare is our second biggest sector. Billions of dollars to our GDP, hundreds of thousands of jobs, and this isn't going to just be a cost shift within the economy. If we do not continue to get the type of Medicaid funding we have gotten in the past, the funds won't shift within the state. It's going to be just the bottom's going to fall out from a bunch of these jobs and billions of dollars of GDP that would otherwise be in the state. It's just not going to come in. And so that's kind of what we're dealing with. There's a lot of sort of finer details that we can look at and talk about, but there isn't some sort of magical pot of money somewhere that's going to sort of fix this problem, which is what we've really been trying to convey. And I think moderates have been understanding.
I think one of the things, too, that we didn't discuss really is that these cuts really undermine the tenets of the Medicaid program, where we've had kind of, age, blind, and disabled populations historically held in a safe place with stable funding. There's discussion that could undermine the 50% FMAP and lower that downwards to 45%. And then, I think things that we know true about Medicaid, so moms and children, like we know that those groups have, over the 55 plus years of the program been held in a safe place. We have the EPSDT program that provides specific provisions, and those have always just been kind of what I would kind of call sacred populations, where when there are program cuts or budgetary effects, those populations have always been meant to be held whole. And I think, part of what is a little discerning about this $880 billion that's kind of being floated in Medicaid reductions is that, to achieve that would undermine all really of the tenets of the Medicaid program and the foundation of that program. And it's very interesting because, last night we met with a bunch of the folks here for State of Reform that are going to be part of the panel discussions today, and they were sharing a lot of their personal experiences about, taking care of disabled relatives and moms and dads that are in need of long-term, skilled nursing facility care, which is primarily, supported at the cost of the Medicaid program, and just kind of some of the safety net, what we've known as the safety net. Medicaid kind of holds the program together, and then I think, we look at the safety net kind of under Medicaid, and that a lot of what is being floated at the federal level really kind of would undermine both the Medicaid program and that safety, the core of the safety net. So it's, I think it's a very perplexing time for state agencies, state administrators to really look at and really understand the complexities of like what may happen. And even I think, Meaghan, you were talking about the rainy day funds. I mean, we know some states have significant rainy day funds, but maybe that would carry like a half a year or a year at most. And then it's what do you do for sustainability kind of moving forward? So I think those are all things that we'll all be as people that are focused on healthcare and providing essential services to the most vulnerable. We'll all be really focused on the road ahead over the next few months.
Yeah, I think it's critical to talk about the people. I haven't spent a lot of time talking about that, but I come to this work from disability advocacy. There are a lot of numbers that get thrown around about like what percentage of us have a disability, and I think a low estimate is 40%. 40% of us in America today have some type of disability. It's often, many people think it's higher than that. People underreport a lot of things due to stigma. They don't get the care that they need. A lot of illnesses and endocrine things go undiagnosed. But the truth is, if you are lucky enough in America to live long enough, you will probably become disabled. And Medicaid doesn't provide services for all disabled people. Many people eventually receive care with Medicare. Many disabled people work, and the vast majority of disabled people work and then therefore have some kind of employer-sponsored health insurance if they can work full-time. But it's critical to acknowledge that this is an attack on sort of a partisan majority of us. That's what attacks on Medicaid are. And not only that, but let's just say out loud, the number of sick people is not going to get smaller. Okay? Like, we can't just decide we're not going to spend money on this and they're going to stop going to the hospital. Okay? They're not. They're going to still go to the hospital. My wife and I have a 9-month-old, and my wife got a very sudden, very severe case of preeclampsia, and we spent 3 months in the NICU with my son, who is now very healthy and chubby and everything he's supposed to be. But a lot of these kids all over the place in the NICU were on access. And those moms were going to go to the hospital when they got sick, no matter whether their kid was on access or they were on access or whatever. They show up at the hospital. And I'm from rural Arizona. I'm from Pinal County. And so we grew up, my hospital was Casa Grande Regional Medical Center, now a Banner Hospital. And, that place is an important part of our community. That's where I said goodbye to my grandparents. It's where, I went when I had a Little League injury. It's where my friends who became nurses got their first jobs. And one more kind of fun story, it's where my dad had to go after he got totally leveled by his doubles partner playing tennis, and his doubles partner was the chairman of the hospital. So he got very good care at that facility. But, that's the rural hospitals that will struggle, and many of them will close, are like these critical community foundational places. That's what takes care of us in our worst times. On our worst days, we're in those hospitals. And they will still need to provide that care. And if they cannot afford to do it, they're gonna close. And this is like end of days stuff. I know you guys all get it. This is why I lost my voice, by the way. I'm just shouting endlessly. But I think it's critically important to say that. And I don't want to get too much into the weeds, but I do just want to mention the other mechanisms that are under attack, like directed payments, which a lot of people don't really understand. The hospitals don't get paid enough based on regular Medicaid reimbursement to stay afloat. They don't. And so, and this has been reported, I think, really sloppily by basically everyone in the news. Like, some people are calling it a loophole or a scam or a trick. I read something this morning that said directed payments are like a trick that the hospitals use. It's like, no, it's a very thoughtful mechanism that we developed, healthcare experts developed, to keep rural hospitals and some of our other hospitals afloat. And it's not as big and flashy as the FMAP stuff, but this too is under attack. They're looking to cut wherever they can. And anything that's going to reduce the amount of money that our hospitals take in, especially our rural hospitals, is an attack on Medicaid and is going to put those hospitals at risk. And I'll keep saying it, there just isn't money to make up for that. And so it's really, to the extent that you guys have lobbyists in the room or at home, thank them, because this is hard work explaining this stuff to people who don't deal with this stuff very often. And there's some really sophisticated advocacy going on here in Arizona and in the Beltway. And it's a shame that we have to, because I saw a recent poll by like a Trump, a sort of Trump-backed polling agency, that like 71% of Trump voters support Medicaid. And it's like, why are we here? It's sort of mystifying to me. 71%. There's like nobody in the Beltway who has that approval rating. Medicaid is more popular than any politician in Washington, D.C. But we're doing this. We have to do this anyway. And so, I guess that's end of current rant.
Well, Meaghan, we really appreciate you coming to speak with us today and to help us open up the day's discussions. I know we're going to have many stimulating conversations today about federal changes and the safety net, and a number of cutting-edge things that are hitting our healthcare industries now, especially on the financing side, as people are more concerned than ever about budgets and the ensuring that there's funding to sustain the system that we have and to keep our communities and our citizens healthy and prosperous.
Thank you, and thank you guys for putting up with my voice.
Thank you, Meaghan.